Okay, so welcome everybody. Um, we are so happy that you could join us. Today's webinar is called Best Practices in Interpretation Services for Latino Communities in Need of Behavioral Health Services. Our webinar will be presented by Cecily Peebles Rodriguez. You can share the next slide, Cecily. For those of you who are joining us who are bilingual, we do offer simultaneous translation to Spanish. Tenemos traducción simultánea al español. So if you need translation, just click the interpretation tab and then click to Spanish. And you'll be able to hear our presentation in Spanish. Next slide. So just a few housekeeping items during today's webinar. Just remember that this event is being recorded and it will be shared through our website. All participants will be muted and the cameras will be turned off. Please make sure that your computer speakers are turned on and up to hear today's presentation. If you have any technical issues, please send a message to the Hispanic Latino Behavioral Health Center of Excellence on the chat box that we have here at the Zoom platform. If you have questions for Cecily, we ask that you use the Q&A tab on the toolbar. You can just type your question and hit send, and we will be addressing questions at the end of the presentation. Also, we appreciate that you complete our evaluation, which will be shared at the end of the presentation, and we will also share a copy via the chat box, and also we will have it on our website. Next, thank you. So, as I mentioned, after we complete the webinar, please complete the evaluation. We will provide a link to this evaluation through the chat. As you know, this is important for us as it will allow us to continue to do the type of work that we'll be doing, that we have been doing, and we continue to do. You can also scan the QR code at the end of the presentation to complete it, and you will receive a certificate of attendance by email approximately a week from today. Next slide. Those of you who are joining us for the first time, the mission of the Hispanic Latino Behavioral Health Center of Excellence is to advance and support the sustainability of behavioral health equity by promoting community-driven, culturally grounded, and person-centered prevention, intervention, multiple pathways of recovery, and recovery supports for diverse Hispanic and Latino communities. Next slide. Next. A brief note on identities. The Hispanic Latino Behavioral Health Center of Excellence recognizes the complexities associated with gender and ethnic identification, as well as the right of all individuals to self-identify. The centers use the term Latine with the intention of both facilitating a fluid reading and pronunciation, and also supporting an inclusive and respectful language. As you know, Latine is a gender-neutral form of the word Latino that uses the letter E at the end, an idea native to the Spanish language. Next slide. So you have Cecily's information. On this next slide, I will say a brief note on her work. Cecily Peebles Rodriguez is a dedicated leader currently serving as the Associate Director for Research and Organizational Innovation at the Virginia Tech Institute for Policy and Governance. With a robust background in applied research, her work focuses on leadership and management in public health and human services, including critical topics such as language access, migration and resettlement, cultural competence, and organizational equity and inclusion. I'll let Cecily also introduce herself.
Great. Thank you so much, Thaddeus. It's an honor to be here with Eric and you and everyone at the Center of Excellence. And I am really happy to be speaking on this topic. We'll spend about 75 minutes going through some themes, concepts, and practical ways that you can improve utilization of interpreters in your practice. Um, my audience, I'd love to have folks, if they are interested, kind of throw open in the question and answer, where you're from in the world and maybe what you do. Are you a clinician? Are you a program manager? Are you a researcher, faculty, anything that might help orient the focus of my talk. So I think you do that in the chat. Yeah,
We
thank
have a
you.
few in the chat. Yes.
Yeah, great. Yeah, so just help a little get an understanding. Folks are all over. I see my own peeps from Richmond, Virginia, where I am a proud community member, and thank you. So a lot of some clinicians, some outreach folks, community engagement. Great. Thank you for that. The point of our discussion today is kind of to give a broad overview of the subject of interpreters in behavioral health. And kind of talk a little bit about some of the things I'm interested in exploring as it relates to language services, language access. And so when we talked with the Center of Excellence about maybe another a theme related, we kind of started to think about the ideas of social determinants of health as they connect to language access, as well as this idea of language justice. So we'll talk a little bit about that early on. I call them newish and emerging concepts, although they've been around for quite a couple of decades. It just seems that now there's a renewed interest, or rather sort of elevating these ideas of language access and language justice into more of a mainstream health and human service world. Then we'll talk about the importance of using trained interpreters, some of the common practices that trained interpreters are taught in their professional programs that folks who utilize interpreters can leverage to enhance their communication in various encounters. Then we'll talk a little bit about strategies for working with untrained interpreters. I think of this as sort of in our behavioral health world as sort of harm reduction, and the idea that we're going to encounter situations where we need to use untrained interpreters. It's just a given. So what are the ways that we can use untrained interpreters, ad hoc interpreters, to try and increase the quality of a given clinical encounter? And then I want to introduce you and, kind of explore some of these interesting themes that I like to think about in behavioral health settings in particular. So that's what we'll do. I understand that Darius and Eric will be helping with the chat box, and feel free, both of you, to just interrupt me and holler out if somebody has a pertinent question. I will set aside some time at the end around 1:15. I'll target to stop, and so we can ask questions at that point too. Okay. So let's get started. So in terms of, this idea of language spoken as kind of a social determinant of health, what we know about the LEP populations in the US is that limited English abilities make them vulnerable particularly when it comes to the healthcare system. A 2015 study from the Joint Commission showed that patients with limited English proficiency experienced adverse health outcomes at a markedly higher rate than English speakers. Joint Commission, of course, governs hospital quality and assurance, and these were studies out of hospital settings. Other research shows that people who are limited English proficient experience high rates of medical errors with worse clinical outcomes than English proficient patients and often receive lower quality of care by other metrics. Multiple studies, including one by Green and Z from 2017, highlight that. And studies show that persons who speak languages other than English in the United States also perceived poorer patient-physician interactions compared to those who primarily speak English as well. So as we know, what we know about social determinants of health, these kinds of disparities are clearly connected. Language access is a critical social determinant of health, as it obviously influences how individuals navigate the healthcare system and access necessary services. Some of the ways that I thought were worth bringing up to kind of highlight this are here in these bullets. So, when we think about communication barriers, these result in inadequate diagnoses, improper treatment, medication errors, which ultimately, of course, affect health outcomes. Health literacy challenges, of course, without connecting literacy to a person's language, individuals can struggle to comprehend health-related materials, instructions, and recommendations. In terms of preventative care, when patients can't communicate their needs or understand the importance of these services, they are less likely to engage in proactive health management. Of course, in emergency or crisis situations, language barriers can delay or complicate emergency interventions, which of course put patients at greater risk during critical situations. Those of you involved in mental health and psychosocial support would recognize that speakers of non-dominant languages may feel disconnected from larger communities and healthcare networks, leading to isolation, and the lack of social support contributes to poorer health outcomes and exacerbates existing health issues. In terms of patient engagement, communication, of course, is really essential for sort of that therapeutic alliance, that engagement of patients in their own care and well-being. So when patients understand their health conditions and treatment plans, they're much more likely to adhere to recommendations, which ultimately lead to better health outcomes. And lastly, among others, policy and advocacy. Limited language access can impact individuals' ability to advocate for their own health needs or navigate insurance, healthcare policies. And of course, this can perpetuate disparities in health equity as well. And then this another concept that I'm still exploring myself and learning more about and thinking about how it connects with language access and interpreting and translation, et cetera, is this idea of language justice. And this has actually been around for quite a while. But again, like I said before, some of these things are just getting attention now, sort of in more mainstream, cultural competence, health equity sort of worlds. And this refers to the idea that individuals should have an innate right to express themselves, understand information, and that they have rights to participate in society in their preferred language, not just the dominant language of a given country. And the concept really emphasizes in a country like the United States the importance of linguistic diversity and the ways that we can ensure equitable access to resources and services and opportunities for people of all languages, not just sort of putting everyone in a box where English is the expected language for governing and for civil society. I'll just leave those two kind of themes with you. We weren't intended to sort of dissect these things, but I think they're really important when you think about not just the healthcare of individuals, but how you create communities and environments and societies that ensure people are able to engage in their communities regardless of the language that they speak. So switching gears, actually not yet. I thought about, okay, so it's all great to talk about language justice. What does that mean? And really, so I wanted to pull out for you implementers, which is what a lot of us are. We take a program and we have to implement it, or we take some sort of engagement or intervention and have to implement it. And I wanted to be able to kind of clarify what would language justice or the implementation of language justice look like in action. And so I pulled up, some of these bullets in my mind, and the way that we implement or apply language justice would be things like ensuring that information and material is available in multiple language. And it's not just a special thought, but it's part of the mainstream operating of an organization or of an initiative. It's not something you think, oh, should we put this into another language? But, oh, yes, this is going into another language as a part of your standard operating procedures. And that's things not just like documents, but signage and websites that ensure individuals have access to the vital information they need in their preferred languages. Things like offering on-demand interpretation, we'll talk a lot more about that today. Actively involving multilingual community members in ways where they can influence decision making. And hiring bilingual staff, not as something special, but as a part of just, again, sort of your normal operating procedures. Thinking about how community meetings are held and how you gather information from people who speak other languages other than English so that everyone can participate fully. Ensuring that you're doing trainings for staff and service providers on things like cultural competence, maybe structural competence, effective communication strategies, and the like. Making sure that organizations have comprehensive language access plans that outline really well and fully how to meet the needs of non-English speakers, including strategies for outreach, resource allocation, evaluation of language services, which is a kind of a problem in and among itself that is needs to be thought of more deeply. Then things like advocating for policies that protect language rights of people, promoting linguistic diversity. This might include things like, I'm not sure about other states, but in Virginia, supporting and advocating increased reimbursement rates for interpreters. Ensuring that procurement people understand that they want to be explicit about budget items in proposals related to language services, et cetera. Also, understanding and employing the right kind of language technology, sort of knowing that our world is moving in the speed of light as it relates to technology, and there are some really good tools out there for real-time translations and interpretation, but making sure you understand them, the pros and cons, and you're using them in ways that are useful to people. And let's see what else I want to talk about. And then also kind of promoting and normalizing linguistic diversity within communities. So not only, celebrating those things, but just sort of working towards this idea that we are a multilingual country and the default may not necessarily be English all the time. I know that can be kind of provocative, but But that's sort of the essence of language justice. So um, it's about creating equitable systems where everyone can fully participate, really regardless of their background. And the kind of the mission of this concept or the idea of language justice is kind of requires an ongoing commitment to dismantle those barriers and to think about how we promote inclusivity in ways that we may not have been in the past as it relates to language. So let's move on. Let's talk a little bit about interpreting the profession of interpreting, and to kind of set us out. I want to tell you about some of the terms I use way too much in this webinar. I know there are folks here who probably work a lot with interpreters, maybe super familiar, maybe even be interpreters, right? So these may be familiar to you, but we can't take it for granted that it's familiar to others. So, there's this idea of source language and target language, languages of service, meaning it often refers to the language used by the individual being served. Um, Limited English proficiency and English language learners is often used kind of synonymously. There are movements and have been movements for quite a while to think about this terminology in strength-based ways, right? And so in health and human services, it's very common to use this acronym LEP, Limited English Proficient. Which of course gives it kind of a negative connotation, right, with the idea of limited. And so years ago, folks in education sector started to think about some of the more positive ways that you can describe an individual who does not speak English fluently, and with the acknowledgement that most people learn a language over time when they are in a society where there's a dominant language. Most of the time people learn. So it's this idea that you will learn to a degree the language. So let's call it ELL. And so, but in the kind of the federal language, Health and Human Service folks tend to use this idea of LEP, and education folks tend to use this acronym or this of ELL. I'll say the word encounter or session a lot. That's kind of the time period in which an interpreter is being used. And language access services, which are kind of all those components that make an organization able to support someone whose first language is not English. Now, if you can do me a favor and think about this question. What do you think is the most important relationship in a behavioral health encounter? And you can throw it there in the chat box. Is it the interpreter and the individual? Is it the provider and the interpreter? Or is it the individual and the provider? You guys are smarty pants. Yes, yeah. So most people are choosing C, which is the individual and the provider, right? And we have two interpreters here, maybe more on the line, supporting this webinar. And what we know about interpreting is that the interpreter is meant to theoretically sort of be a simple conduit of information from one language to another, right? And so these other two relationships, the interpreter and the individual, and the provider and the interpreter, are really just mechanisms for communication so that the individual and the provider can have the best encounter possible. Okay. Okay. So Um, kind of as I said before, untrained interpreters are widely used in healthcare settings. They're widely used in behavioral health settings. They're widely used in every public setting. And I'm kind of the poster child of somebody who's a wannabe do-gooder who really learned over time that, being someone who wanted to help as an untrained interpreter could have possibly been a greater risk to people than my help. And so I see this a lot. People, this is an imaginary woman. She's not real. I mean, I'm sure she's real, but she's not anybody I know. But this statement here, between his broken English and my broken Spanish, we got by. And that's really how a lot of our community behavioral health organizations operate. Um, Untrained interpreters often have very little language competence, especially in specialized settings like behavioral health. The terminology is not necessarily familiar to people. There is little to no knowledge of the protocols used for increasing or ensuring effective communication. And there's no discussion of untrained or ad hoc interpreters about their relationships and kind of the dynamics that happen in a clinical setting when an interpreter is not sure of their role. So and as I said, I'm kind of a great poster child for this. I went to undergrad here in my own backyard, Virginia Commonwealth University. Shout out to the Rams. And I studied Latin American politics. I was interested in studying the social culture of Latin America, and I also took Spanish classes, right? So I graduated from my undergrad and I moved to El Paso, Texas. And because I spoke a little Spanish and I'm kind of a sabelo todo, right, a know-it-all, pushy, I was asked very often to do interpreting. And I had a little Spanish and I ended up interpreting in community settings of all kinds. This was back in the early 90s when people didn't really care who was doing any interpreting in court systems, in foster care systems, in social service systems. I was an interpreter for a community health clinic. I interpreted for a clinical social worker who did family therapy. I interpreted in front of judges, immigration courts, where people's lives were being determined about whether they were going to be able to stay in this country or leave. In family courts, where people were faced with whether they were going to be able to keep their families together or not. And I did all of this, with a full heart, right? Like I want to help. I'm interested. I um, I my heart is in the right place, and I did that for hundreds of people potentially over a decade. I moved back to my hometown in Virginia, and I decided, well, I needed a job. So I thought, well, I've been doing all this interpreting and I kind of like it. And so I'm going to go and take an interpreting class. And these are not national certified classes. These are kind of community interpreting classes. And I went to take the proficiency assessment and I failed it. I failed the assessment. And these were like words like myocardial infarction and femur and cerebellum and things like this. And that really, really impacted me. And I thought about all of those people that I interpreted for over the course of 10 years or so. The gentleman who was dying of AIDS and in hospice care in an immigrant shelter that I worked at, and the folks that I interpreted for in court settings, and I thought, what was the damage that I actually caused when I don't even know the terminology to use. What really did I do to help those folks? And what was the, sort of the balance, right, between helping and hurting? And it was an incredibly humbling experience. And it made me very passionate about working sort of in this naive world where we think we can do this work without being trained. Now, of course, I went back and I studied terminology and I ultimately passed that proficiency assessment. And I did work as an interpreter for a while. And the more I learned about it, the less I decided it was a good job for me for some other reasons, memory and things like that. But I'm the perfect kind of candidate for being this woman right here. And I would suspect out of the 100 or so people on this line, there's probably a couple others who could probably think that they've been in the same place that I have. So that's just sort of my come to Jesus moment where, you got to kind of think about where your ego can sometimes get in the way of these things and where your desire to help people can get in the way as well. So, if I haven't convinced you, untrained interpreters are problematic. I'd like to show you a couple more slides about this. Um, this is um, a snippet from a journal article that's cited here. Um, and a couple of important things come out of this research. So I wanted to highlight it. This talks about comparing the accuracy of interpreters and in-person professional interpreters versus professional video conferencing interpreters versus ad hoc interpreters, which was calling before sort of untrained, right? And the conclusion of this study was that inaccurate interpretation is common, which I think, first of all, is important to know that, communication is complex, and even the most well-trained interpreter is going to have inaccurate interpretation. And the more frequent, and these inaccuracies are more frequent when ad hoc or untrained interpreters are used compared to when professional interpreters are used in person or virtually. And so, kind of for this reason, professional interpreters, we have come to really prove, do increase access to higher quality medical interpretation. And I use medical broadly because I think that it is not too far of a reach to say that behavioral health is a area of health and medical health that has specialized terminology, specialized assessments, specialized treatment plans, and all of the knowledge about that for is critical for both professional interpreters and ad hoc interpreters. Another study that I think is important to know is that interpreters, even professional interpreters, are more accurate when they are doing non-technical interpretation as opposed to highly technical interpretation. And this really supports our argument that people who interpret for us need to be trained in specific terminology that we use in our disciplines. And I'd like to just take a moment. A dear friend of mine, someone who was really passionate and led and was a leader in sort of the behavioral health interpreting field over the past 10 years. Dr. Eva Stitt passed away this week last year. She helped to write a curriculum on behavioral health interpreting that we still use here today. And I'm just sending her love and affection over this because her work lives on, and she has helped us kind of address some of these things where we know that behavioral health terminology is specific and it is complex, and we can't assume that an interpreter who has been doing court interpreting or has been doing interpreting for famous applications or WIC applications is competent to do clinical interpreting in a therapeutic setting. Um, so just a couple of things I think are kind of interesting is the way that errors happen in interpreting, and we don't think about sort of all the ways that communication can get derailed, especially when we're translating from one language to another. So these are statistics out of a study from the Center for Advancement of Urban Children Pediatrics. They did a 7-month study that found that 52% of untrained medical interpreters simply omitted or left out vital information in an encounter. So just left out words, left out phrases, which of course, if you think about your own clinical experience or needs, those are, somebody can't just leave out information, right? You need that information. 16% of medical interpreters interpreted with false fluency, meaning that with these interpreters, they appeared to have this fluency, which is a lot of how I operated back in the day. When they interpreted, they just really didn't interpret accurately. And so false fluency is often when an interpreter uses a word or phrase that doesn't actually exist in that language, or maybe known colloquially, but not in the broad language. 13% of untrained interpreters replaced other words during an encounter to transmit the message from the source language into the target language. That resulted in inaccurate interpretation. Maybe they called a delusion a hallucination in the language of service, or maybe they said someone will have an assessment instead of a screening. Maybe they called an MRI a CAT scan or a PET scan. Other things like are like maybe saying in terms of false fluency, embarrassed, as opposed to being, embarrassed, pregnant, or translating actual into actual in Spanish, when actually maybe the correct translation would be real or verdadero, no? So, oversimplifying complex medical terms, which is kind of editorialization, this idea, maybe saying a little pain versus a patient describing severe or sharp pain, interpreting chronic condition as simply kind of a long-term illness, when the specific nuance of chronic might be important to someone who is doing an evaluation or assessment of that individual. And let's see, 10% of the untrained interpreters kind of put their personal opinions in the encounter session. This is something so common with with folks that I train as bilingual staff interpreters, or even as behavioral health interpreters. We have this desire as humans to help, right? And if we don't understand that the role of an interpreter is a conduit of information, we often will add in our own ideas to somebody's care. And then, I think it goes without saying, I would hope that we're kind of beyond these lessons, but I think it's important to remind us all that, children should never, ever, ever be put in a situation where they're asked to interpret. As many of you are in behavioral health or are behavioral health clinicians, I'm hoping, you're pretty sure that you understand why there are just enormous degrees of power imbalances. There is a lack of language proficiency on both sides, right? I've talked to a young person who was like, I'm in school to learning English, and I learned my Spanish at home. I don't know either language that well, because they're young. It's an uncomfortable role, and of course, it negates confidentiality. And so, to any degree, this is avoided. Even in my my statement of harm reduction. Does not balance out the harm reduction that would be caused to a child who was asked to interpret, particularly in the settings that we're talking about today. Now, on the other hand, trained interpreters, I think, as I shared in this research, they assure, at least from that one study, 70% of the time, somewhere between 70 and 90, that people or patients or individuals have full comprehension of what's going on. It provides individuals with the autonomy that they need to make their own healthcare decisions. It improves people's understanding of healthcare systems. It possibly and very likely avoids unnecessary tests and bad diagnoses. Um, and I think one of the important things about this for me, thinking about sort of the ethical parts of communication is that when we use untrained interpreters who may be doing all of these kinds of things, we're really robbing people of their own autonomy and of their right to make complicated medical decisions on their own. Um, so let's talk about in an ideal world, if you're in an organization or a setting where you have 100% access to the best interpreters all the time, then you might know some of these things. But if you are a provider who does not speak the language, the more you know about the common practices of trained interpreters, the more you can take control of the encounter and even encourage untrained interpreters to follow some of these protocols. So it's just like learning, if you are a I don't know what kind of analogy I want to use, but it's important for a social worker on a treatment team to understand some of the concepts and processes and procedures that the psychologist plays, right? And it's important for the psychologist to know some of the processes, roles, and practices of the social worker. And so the same is true if your treatment team includes an interpreter. So language interpretation is a profession. It's a formal profession and it's a practice profession, meaning that just as with other kind of providers of healthcare services, you get better at it over time, right? You learn the gold standards of your profession. And then as you learn it over time, you start to understand where you can push out the guardrails or where you really need to stay within the guardrails of your profession. It's also, I don't think it's in its infancy anymore, but it's at least in its late, it's in its early preteens, I guess is what I'd say. In that, for the most part, over the last 30 years, we haven't taken interpreting as in consideration as a profession. And a lot of times we still don't. I still get questions from people about where can they find a volunteer interpreter, right? I mean, this is a profession that people need to earn money from, that they do, and the more they do it, they get better at it. And so it's formalized as any skilled occupation. And as such, trained interpreters follow routine protocol. They are expected to have a specific set of skills. They're expected to follow codes of ethics and utilize recognized standards of practice. And the more providers really know about this profession, the better they can support effective communication when they are working with an interpreter. The better they can hold the interpreters accountable for their practice, and the better they can distinguish between a highly trained interpreter and one that isn't trained or is poorly trained. So let's look at a couple of them. Um, One of the reasons I said that I do not do interpreting anymore has to do with some of this stuff. And so it's not just about speaking the language. Like the language is just a small part of what a good interpreter is. Another really critical part is having a good memory. Like, and then also being able to quickly find the equivalent meaning of in one language and then really like process in your brain quickly, like AI would do, maybe, to find something similar or equivalent in another language. It requires a specialized vocabulary and a recollection and memory of those concepts and vocabulary. And it also requires a focus on customer service, on knowing that what is needed from both the provider and the individual, and sort of being able to quickly accommodate and facilitate appropriate communication between those folks. Again, just because somebody learned a language in their home because their parents spoke Spanish doesn't mean that they are naturally going to be good interpreters, right? This is a profession and it has a lot of other attributes that are important. Um, Another kind of important sort of element of good interpreting and what professional interpreters are trained on are these ideas of modes of interpreting. What's here, these four that are here are not the only modes, but they're kind of the modes that are commonly used in a behavioral health and setting. So consecutive interpreting is most common, and it's kind of when someone says something, and then the interpreter kind of waits until there are a few sentences in before interpreting. The speaker often needs to be able to modify their tone and their pace of speech. I'll share with you that the interpreters on this line said that there is like an 8-second delay in when they get the information and for them to go out and share it into Spanish. And so this is that's what consecutive is. So, and it's commonly used across behavioral health settings in particular. Simultaneous is less commonly used. It is when the interpreter is listening to the source language and then kind of speaks sort of at the same time with less delay, right? So it's more at the same time as the original message. This is often in our settings, this is often happening in crisis services. When there's some kind of emergency, the interpreter may be speaking faster and maybe, sort of summarizing in some ways so that they can get more and more information out more quickly. Sight translation is often an misunderstood mode of translation because it's not intended to be long streams of information, but rather very short ones. And so this is when an interpreter reads a document in the source language and kind of simultaneously translates it into the target language. Interpreters who are trained professionally are trained not to do sight translation for documents that are maybe more than 1 or 2 pages. They're also not trained or discouraged from doing sight translation of documents that may need a signature or have some kind of legal binding, because the idea that the individual could hear the information once, then sign it in another language, and then be able to retain it for their own purposes is not a rational thing. So sight translation is often like understanding when your appointment is, maybe reading out some instructions that are not related to some something with clinical significance. Um, and then relay interpreting is often used with, in particular, I think about the Spanish speaking population. You know, this may be often used when an individual might speak an indigenous language and they need a person, an interpreter of an indigenous language, maybe to then interpret it into Spanish, and then the Spanish interpreter interprets it into English. And so it's used with when you need multiple interpreters or you have multiple languages involved in one encounter. It also is very common in American Sign Language interpreting when people might have learned a home sign language instead of formal American Sign Language. So one interpreter understands the home sign communication, and then we'll sign it to the American Sign Language person, who will then interpret it into verbal English. So this is important for in a behavioral health setting, so that you can kind of, if you're in a setting like that, and you may help and you may figure out why professional interpreters are using the kind of speech patterns that they're using. Um, Another important concept that I think is useful for staff, for clinicians, for other people using interpreters is this idea of an interpreter highway. I don't know how often this is used in professional, like other kinds of interpreting settings, like court interpreters or maybe um, community interpreting, but we use it a lot in our behavioral health interpreting classes, and it was actually adapted from a training that I used to teach with Kaiser Permanente, which was a qualified bilingual staff training. And I just really like this when we're talking to interpreters about effective communication. And it's the idea that you ride on this highway in an encounter based on what's happening in the encounter. So um, typically you are, as an interpreter, you're driving in this far right hand lane where it says conduit, right? And a conduit is really just the message converter. And that is the primary role of an interpreter, is just to take one language, turn it into the other language so that both individuals in the encounter can understand. But because communication is complicated and humans are complicated, there's these other lanes that interpreters often have to get in. And so we'll teach interpreters to assume that they come into the encounter just as the conduit. But then something happens and there is a misunderstanding about the language itself, the terminology between the two parties that you're interpreting for, and they need a clarifier. They need somebody to say, oh, well, the individual used this word and it often means X, or it helps to allow the individual and the provider to understand the different terminology that's being used amongst themselves. And then we teach them, we'll go back to your conduit role, go back to lane one and keep driving in lane one until maybe something happens where there's something about a cultural phenomenon that's confusing. The provider is speaking about some kind of American medical system cultural thing, and the individual doesn't understand what it means to, I don't know, take an assessment or whatever, and so the interpreter may have to move over to lane three and intervene and help the individual understand, well, an assessment provider, what is an assessment? The individual needs to understand what an assessment is. So, or it's a cultural thing, like some word that may not have a good equivalent in the English language. And so the interpreter needs to intervene and explain maybe in more detail what that word might mean to that individual. And then the most intrusive, and then of course we tell them go back to the conduit, lane one, and keep driving your car until the encounter is done. And then at some points in time, often we encourage, very rarely does an interpreter use that advocate role. And the advocate role, now this is in classic interpreter training, and there are a lot of great, there's a lot of great work on, how even interpreter training as it sits right now is very Western. It's modeled after very Western medical, biomedical, sort of subjective framework, and so in this way, in our traditional interpreting training, we talk about being an advocate as an interpreter only when you see that the individual that you're serving is the victim of some kind of discrimination, or there is some risk to their health or livelihood. And so we teach interpreters not to get involved in very deeply into the elements of the encounter unless there's some risk to that individual. And yeah, Jessica, I mean, this stuff is really interesting because it sort of breaks up this idea of how interpreting is also a cultural thing, right? So it's fascinating to me. And there's some people doing some really neat work around it. So I think the highway is really good for interpreters to know. And it's also good for providers to know if they're working with an untrained interpreter that, if they have the opportunity to kind of talk about, their expectations in a given encounter, you're hoping that the ad hoc interpreter, untrained interpreter will literally just provide a message converter, but you understand that they should feel free to intervene if there's some terminology problem or if there's a cultural element that you as the provider may not know about. Okay. So one other kind of critical part of the traditional interpreter training is this idea of incremental in intervention. And so these are the same basic highway rules, right? In this other sort of visual, with the idea that, you are assuming that the interpreter is doing the least invasive kind of intervention. So trained interpreters in our current settings are taught how to consider these modes and how they impact a clinical encounter. So they understand that more intervention also means less therapeutic time in the encounter, because they're putting themselves sort of in the center of the work, as opposed to allowing the therapeutic relationship to be built amongst the provider and the individual. And so this pyramid sort of represents the amount of time that the interpreter should spend in any one role, knowing that every time they intervene, they are creating less time for therapeutic alliance in the encounter. And so as we go up the pyramid, the roles become increasingly invasive, which means the interpreters should stay less there. They are less and less in the background, and they become more the center of attention. So, knowing that these are sort of the 3 or 4 protocols, expectations of trained interpreters, how do we deal with or support people who are untrained, because we know that we often use them in these clinical settings, like it or not? It is possible for a provider to have an effective encounter with an individual who doesn't speak the same language that they do if you are able to direct the untrained interpreter correctly. So let's talk about some of the strategies that might help with that. Now, this is something a little more conceptual, and there's a lot of great work about this happening too. A lot has happened in the American Sign Language field, especially because that element of interpretation and language services has been around longer as a formal profession. But what I want to describe here is sort of the difference in the dynamics of health encounters when an interpreter is used. So this triangle here represents that dynamic. So when three people are working together using two different languages in a structured task, three different interactions are occurring, right? The verbal and nonverbal, the nonverbal, and the not verbal and nonverbal. So what develops is a triangle with three sets of pairs or dyads, each one operating at a given point in time. And this model really helps us recognize that the simple addition of a third party inevitably shifts the dynamics of power between individuals and providers. It reminds us that the only one in the encounter who has full access to what's going on at any one given time is the interpreter. And that is quite a shift in a power dynamic, especially in a healthcare related encounter. Interpreting requires a three-way dyadic communication in two languages by three individuals, and sometimes even more in the case of family interviews or group interviews. And so, unlike two-way communication, there's a shift in the power within the triangle. And the only communication really that's taking place between the clinician and the patient is nonverbal. And this is very different than how clinicians are trained, right? They're trained in this dyadic therapeutic model where they are engaging with the client both verbally and non-verbally. And so, although only one of these dyads is operative at any one time, nonverbal communication is taking place with each dyad all the time. And how this kind of shows up in practice is that for all we say about arrogant psychologists or MDs or uh, licensed nurse practitioners, et cetera, LCSWs, they often will defer to the interpreter as a subject matter expert, or even more so, kind of lean on the interpreter for even more engagement in a clinical setting because they are not able to have this verbal relationship with the client. And so I think this is important for folks who are working with interpreters to kind of recognize that this power shift away from the provider really does impact how these three people work together. It impacts the provider in being a little more deferential and sort of recognizing that they don't have all the power in the room like they would typically do in a regular setting. It impacts the client because they are only able really to engage with the provider non-verbally, and that's sending all kinds of messages. And then it impacts the interpreter because all of a sudden the interpreter has all of this power, and it's not conscious power, right? It's unconscious power. And when you have power and you don't recognize that you have it, you can sometimes use it to the detriment of other people. And I'm not saying like, crimes or whatever. I'm just saying like, you begin to own that encounter, and what you decide to do with your power can either make or break the therapeutic arrangement between the provider and the client. So I hope that's helpful, and it might be that you start to observe that happening the next time you use an interpreter. And you might think about, like, what does that power differential make you do as one of these three people? So one of the ways that you can, if you're the provider and you want to kind of mitigate some of this strange stuff going on, you can use this triadic interview process, which is something that professional interpreters also learn. It requires additional time. Oops, requires additional time. There's no way around that. To the degree that you can uh, um, prepare for longer encounters when you have to use an interpreter. That would be important if you are in a position to do that. What would take 45 minutes with an English speaking person might take 90 minutes with using an interpreter, because there's all these other things going on. So what we teach interpreters to do is to have sort of this spiel that they share before the session happens. They clarify the language they speak. They ask the provider and the patient or individual to speak in first person sometimes. They'll encourage people to understand that everything they say is going to be translated or interpreted, so that there is an element of transparency in the room. And they do a couple of other things. And you, as a provider, could have an informal pre-session with your ad hoc interpreter, and definitely have them with your professional interpreters, because they know exactly what to do. That kind of tells the interpreter, well, we're here for this kind of engagement. This person is gonna, I'm gonna be asking them for this or that, or we're doing an assessment for X, Y, or Z. And any kind of information you could have to share with them, especially in a behavioral health setting, because sometimes in those settings, when people are suffering from maybe a crisis, or having an episode, or have SMI, they may behave differently than people would normally expect, right? And interpreters need to be able to predict and function. um, and so the more you can tell them, the better. In that. Then there's the interview. We'll talk about that. And then there's kind of a debriefing at the end. So we'll talk a little about each of these. You'll get the slides. So I kind of already talked about this part, this pre-session. To the degree that you can, check in with the interpreter before you start, you're going to feel better about the encounter. Trust me. And if you can use some of these tips, I think you'll find that your sessions will go way better. During the session, you're going to want to talk directly to the individual client, patient. This helps create or reinforce that therapeutic bond, especially knowing that the only direct engagement that you have with that individual is through nonverbal communication. So, however, you can use your nonverbal uh, um, behavior to positively engage that person, the more you're going to have this alliance with them. Try to speak about one issue at a time, one topic at a time, if possible. It's not always possible, because you're responding to whatever the individual is communicating as well. You can check the interpreter's interpreting, translation. If something that the person said was really, really long, and then all of a sudden the interpreter turns to you and just says yes, you have the right as the clinician to say, tell me more. What else do they say? It doesn't, I know that yes is, I know what yes is in Spanish, but they said a lot more than that. So you have control to get more information if you need it. Then you can watch for things like the changes in patient's tone. So if you know that nonverbal is going to be really strong there, if they all of a sudden put their head down, or they're rolling their eyes or shaking their head, maybe there's a possibility there's something that could be going on with the her interpretation itself, right? Especially if it's an untrained interpreter. Maybe the individual knows that that person has got false fluency, right? So just be tuned into the nonverbals of your individual. Um, if a response doesn't make sense, um, ask for more information, and then keep an open mind. Sometimes logical connections may be different between cultures, right? So what you are seeing as a nonverbal may not be what you think it is in your own interpretation of your own culture. And then the post session is an important part or an element too, which sometimes gets lost because people are rushing to their next appointment or they've got something else going on. But if you have the time to check in with the interpreter can be a part of your team, right? They have some subject matter expertise that is useful to you. Why not tap into it, right? Um, okay, so I want to make sure I'm talking a lot and I want to make sure I have enough time for questions. Um, uh, what Rosemary is saying in this slide here, Rosemary Rodriguez I'm not related. She's a Californian, but she's here in Virginia now. She's a interpreter trainer. She owns an interpretation company and just all around Miss Fabulous. But she talks about what an interpreter is responsible for. And she reinforces this idea that they are responsible for facilitating communication, ensuring completeness and accuracy. And what she has shared over time is that because of this power differential, oftentimes clinical folks or the provider, whoever they may be, often expects the interpreter to be doing all of these other things. So this slide is just kind of a reminder that the interpreter cannot be all or do all in your encounter, right? So it is up to the provider to share the expectations of the session. It's up to the provider to ensure that the communication and the course of the conversation is a therapeutic one, right? The interpreter doesn't know what that is necessarily for that given person. It's up to the provider to monitor the dynamics. It's up to the provider to think about the language they're using, avoid the slang, think about whether they have these acronyms or highly specialized terminology that their interpreter may not be familiar with, right? It's important that they manage or pay attention to the flow. If they're talking too fast, if somebody's talking for too long, it's important that the provider step in and go, hold on, let me hear what the interpreter has to say about what you just said. And then to clarify, particularly the methodological approach. So supporting the interpreter to make sense of the encounter. You know, a lot of times assessments and screenings related to behavioral health are duplicative in their questions, right? They ask the same question in different ways. And if an interpreter isn't familiar with that methodological approach, they may think that that it's the same question, and they may just phrase it in the way that it was phrased the first time they shared it out. So it's important for the provider to say, I'm going to ask a series of questions that may sound similar to you, but be sure that you use the same word structure that I use. Ideally, it's another seminar or webinar, but you don't have people interpret assessments. You have them translated and validated in another language. So an interpreter is not a clinician, a diagnostician, or a decision maker, but they can be used for their cultural and linguistic expertise, and you should leverage them for that reason. You may also want to inform untrained interpreters that there are standards of practice for professional interpreters. It may feel like it's out of the scope of your work, but it will help you actually have a better encounter with the individual you're serving if you do spend time and do some of this with an untrained interpreter. So you're asking them to interpret everything that's happening in the room, that to the degree they can into first person. There's some behavioral health stuff that impacts that. Avoid slang and speak about one thing at a time. Um, and just kind of hold them to some sort of accountability with the way that they're doing their interpretation, instead of just assuming that they know everything they should know to be a good interpreter for you. Now, a couple of things as we wrap up. The last few slides are about particularly interesting things to me about the uniqueness of behavioral health settings. A lot of what I've already described holds true for interpretation in a behavioral health setting, but what I found is that a clinician who understands more about the nuances of interpretation in behavioral health is better able to utilize the skills of an interpreter in this session. So a couple of these slides that are following are really kind of just explanatory in nature, and maybe something you want to pursue if you have further questions. This quote from Dr. Robert Pollard, he is at University New York in Buffalo. He's an ASL interpreter and psychiatrist. And this is one of the most profound quotes that I know. And it really frames the tension present when we think about the connection between behavioral health services and interpreting. And now he's a psychiatrist, so he's talking here about psychiatry. But we can extend this idea to other roles in behavioral health as well. And really, outside of developmental disability settings, I can't think of another area of practice in healthcare that's more dependent on the effective communication for its success. So he says here, psychiatry is unique among the medical fields in that most of the symptoms are conveyed by or through communication. And communication is also the primary method or nature of treatment. So without effective communication, can you actually have effective behavioral health care? Is kind of what he's explaining to me. And I feel like if we could really get behavioral health systems to understand and recognize the relationship between interpreting or communication, language communication, and behavioral health services, I think we could have a much more robust language access sort of system in our systems as a whole. Another element is this idea of language and emotions. And so I don't know how familiar folks are with this, so forgive me if it's sort of duplicative, but our world is filled with rich and layered meaning that sometimes in English, despite its own unusual vocabulary, really renders them practically untranslatable. And so this was something, this graphic here is the result of, and it's cropped out, the citation's cropped out, but it's Bloom's taxonomy of emotions, basically. And it's all over the world, looking at languages all over the world and then trying to translate them into English. And the argument with this research and this graph is that there are so many languages across the world that describe emotions differently, and that despite such, they really can't be translated, even though we try to translate them into other languages. And so a couple of thoughts around Spanish emotions. There are folks that argue, that there are a lot of Spanish emotions that are considered untranslatable into English. Some of the the quick searches I did for this argument was like vergüenza ajena, feeling embarrassed on behalf of somebody else. There isn't a direct translation of that. Saudade, which I thought was a Portuguese word. It's kind of melancholy, is there a melancholy longing, right? So like, what is a translation of that emotion? Empalagar, feeling overwhelmed by sweetness, sobremesa, that nice time after dinner conversation. Maybe you all have others. I'd love to see. Yeah, pena ajena. Yeah, Liliana, nice to see you. Malcriada, yeah, malcriado. Any others? I was thinking vacilando too. Oh, yeah, Jennifer, I don't know that I wouldn't even know how to pronounce that, but what does Schadenfreude mean in German? Maybe you'll write it in there. Yeah, and so endurance, okay. So yeah, so there's also this assumption on behalf of a lot of oh yeah, chulo, is on behalf of a lot of non of speakers of even multiple languages that we can easily translate this stuff, and so we don't have to spend great attention to it. When in reality, there's a lot of this stuff, and there's so many. One day I just want to write a book of case studies about all of the ways in which communication has either helped or derailed, good intentions in behavioral health. Oh yeah, you've got them coming. Lydia. Hello, Lydia Empachada. Empachado, yeah. Anyway, okay, so you get the gist in that. Last couple of, oh gosh, we're running out of time. Let's see what I want to do. All right, I want to share two more slides and then I will wrap up. So there's a couple of other themes I wanted to share, in particular around clinical assessment. So it isn't uncommon that interpreters, especially untrained interpreters or interpreters who are not familiar with behavioral health settings, who will attempt to normalize, quote unquote, a patient's psychopathology to protect the patient, maybe from medical authorities, or they just have very little understanding of what's going on. So they, in their course of language, they want to normalize that behavior. Interpreters may sometimes fall into the trap of trying to do their best to make sense of what the patient's disorganized or illogical responses are. So they may, because their role is conduit and clarifier, their whole role is to make sense of the communication. And so for a provider to say to an interpreter, not everything this person may say is going to make sense, or don't try to make sense of things you don't know, just share with me what the person is saying. Some interpreters may feel pressured to give more information to the clinician or the provider than the patient gave to them, which is also an attempt to kind of normalize or make sense of things. And so these are some of the things that are happening, and they interfere with the quality of interpretation and affect the working relationship, when really maybe 3 or 4 minutes of sharing what the interpreter is about to enter into might really help the encounter itself. Let's see this. And then in terms of behavioral health therapy in general, most of you know that the clinician's perception of what is normal or abnormal is often shaped by factors that are really totally subconscious to the therapist themselves. In cross-cultural psychology, scholars talk about this idea of spread effect, which refers to the power of a single attribute to invoke a list of characteristics. This spread effect, it does affect how interpreters interact with clients from different backgrounds. And so when this happens, a negative attribute, like maybe the inability to speak English, will lead to negatively evaluating the client or the patient. whereas a positive one, like being fluent in English, can invoke a more positive view of the client. The effect on this of this on individuals is often subtle and unconscious and largely problematic, right? And so clinicians and interpreters both are really, it's really important that they understand, especially because these verbal cues are the most powerful in the room, that this is going on. In terms of group therapy, there's a guy out of Georgia, Hammerdinger is his name. He's an ASL instructor and a researcher, and he suggests that in group therapy, interpreting is really only successful under some of the most controlled situations. So, like a support type group where there's a lot of information driven by the leader themselves, right? So it's often just one person talking, or groups that are staff intensive, maybe a group that has multiple people in it. Educational groups maybe are effective where there's a lot of independent work going on with the individual or client so that the interpreter is just sitting with one person, or groups that are really just lectures by one single person. And then the last concept here is around this idea of neutrality. We're really starting to understand, because of the bias work that's being done all over, that also this idea of neutrality, I think in general in healthcare, but also within the interpreter settings, is largely a myth. Interpreter neutrality might describe any relationship, perceived or actual, that the interpreter may have had with any participant in an interpreting encounter and affect how kind of the impact of the encounter. Metzger, this I've cited here, coined the term interpreter's paradox. And that's the idea that although interpreters have traditionally attempted to maintain a neutral status, a number of sociolinguistic studies have shown that they simply cannot act as a conduit of information, especially in highly complex encounters. So, in other words, the interpreters really have the power to influence the discourse just by their sheer presence, the words they select, the body language that they select, maybe even subconsciously in a treatment setting, and their level of participation all impact this discourse. So just as we talk to clinicians and we do supervision with clinicians and that kind of thing, if you have interpreters working with you on a regular basis, kind of working with them through these ideas of bias and neutrality, and then also supporting them just like you would support your social workers or your psychosocial rehab people, to understand how vicarious trauma happens or secondary trauma happens, is also very important. So in order, it's 1:30. I'm happy to stick around if people have questions. I apologize for taking too long, buddies. I get into it and can't stop. But the slides are available. And also, I'm happy. Clearly, you can tell I love this, and I'm happy to talk about it anytime.
And we appreciate everyone taking the time to join us. It was an excellent presentation. We can take a few minutes for questions, and I would just like to remind the audience that to please complete our evaluation. I am sharing it in the chat box, and the slides were also shared via the chat, and they will be available along with the recording of today's session on our website. So we invite everyone to take a look at our website and see this and other sessions we've had. So let's take a look at the Q&A. We have a lot of great comments here. One question we have from Joshua: what are your thoughts on ALTA certifications? I think you're muted.
On what kind of certification?
Alta, ALTA.
Alta. Well, my understanding is Alta is just a language company, right? So it just does a language assessment test and measures your level of proficiency. If they have something else going on, I'm not familiar with it.
Okay. We have another question from Jessica. Are you familiar with any organizations or resources that interpreters can connect with? I would love to attend more trainings to reflect on the work I'm doing.
Um, well, yeah, there's a lot of them. Maybe, Darius, we were going to put together a little information sheet. So I'll commit to pulling in. There's some cool companies, they're for-profit companies who are doing like trauma-informed interpreting and stuff. I can't remember the name of it yet, but I'll pull together some of those resources into that document.
Mm-hmm. Yeah, we'll also be sharing that on our website.
Okay.
So we have a response, yes, please, an info sheet will be wonderful. Uh, it just a comment here that the Google Cloud Translation AI now covers 189 languages. So it's another element for translation, right? Okay, we have a question. Okay, that was answered as well. So let me see if we get another one via the Q&A. Some agencies use ALTA to certify their clinicians to be officiated as interpreters. So that's the company you just mentioned. Some questions about certification and some responses to that. So yeah, I think that
I do see one that I get all the time. It's Sonia Tamez. It says, how can you politely address clinicians attempting to speak Spanish poorly to the client and not be rude? I think I'm not a good person to be the one describing this, um, but in some we teach in our interpreter classes like the difference between assertive communication styles, passive aggressive, et cetera, et cetera. And we practice like assertive ways to confront people like this. And this is so common. And so I can't, it has to be based on your own sort of communication style, but it is not unreasonable to use a story like mine. I know this woman, she talks about, having been wanting to do the best she could, but really doing a disservice by speaking Spanish as a non-native, untrained interpreter. So I don't know if there's a quick and easy answer to that, but, in some ways that requires bilingual staff to stand up and advocate for language services and be the ones that are kind of causing trouble, good trouble about this being allowed, right? Being something that the organization allows to happen.
Thank you. Thank you for your response. Okay. So I think we don't have any more questions for now. Again, Cecily, I appreciate your presentation. It was excellent. And I appreciate everyone taking the time again to join us. Do join us for future events. You'll have the slides as we mentioned and the evaluation. So thank you so much. Have a great afternoon.
Thanks so much.
Take care.
All right, take care.